Good day. Today we're still busy with the hypertensive conditions during pregnancy, labor and postnatal, and I'm still Anna Nolte. And today we are going to do the physiology and the pathophysiology around hypertension, the physiology of the cardiovascular system and the pathophysiology of the hypertensive conditions. Now, if we look first of all to the cardiovascular changes that happens during pregnancy and obviously have an influence on blood pressure, we see that there's an increase in blood volume during pregnancy because there's an increase in plasma volume and there's an increase in all the blood cells. There's an increase in white blood cells and red blood cells, the platelets, etc. And that all causes an increase in the blood volume. And because there's an increase in the blood volume, it obviously has an effect on the heart because the heart has to work much harder now to pump this blood out. So we have an increase in the cardiac output, which eventually will also cause an increase in the blood pressure. I think I've usually used the example of a hose pipe. If you connect a hose pipe to a tap, and the end of the pipe is being closed and you open the tap, the wider you open the tap, so the bigger the cardiac output, the bigger will be the pressure in the pipe. But during pregnancy, we have a hormone, progesterone, which causes relaxation of all smooth muscles. Blood vessels are being made out of smooth muscles, so we get vasodilatation of the blood vessels. The blood vessels literally become wider, and that instead of the fact that the blood pressure increases during pregnancy, we get a decrease in spite of this increase in blood volume and increase in cardiac output. So if, coming back to our example of the hose pipe and the pipe, if the hose pipe is being made of a very soft plastic that can expand, obviously it will make that the pressure in the hose pipe will be less than when it's a stiffer pipe. Now, that's basically the very important physiological factors that you need to remember. Now, when we come to the pathophysiology of preeclampsia specifically, preeclampsia, there's a lot of theories about how preeclampsia, where it comes from and how it's being formed, etc. Now, I'm always saying that I think preeclampsia is as old as Adam and Eve, and we still sit with a lot of unknown factors around preeclampsia. So there's a lot of theories about what's going wrong during a pregnancy to cause preeclampsia, and why do some women develop preeclampsia and others not, and so on. Now, there are lots of theories, as I've said, and one of the theories that stands the longest, and that's what we will do today, is that preeclampsia happens or starts with the formation of a normal placenta. Now, this just shows you the formation of a normal placenta without any preeclampsia. Now, as soon as the fertilized ovum has been arriving in the uterus, it implants itself in the side of the uterus. This pink here, at the background is what we call the decidua, or in non-pregnant terms, the endometrium of the uterus. The endometrium of the uterus becomes the decidua during pregnancy. Now, as soon as this fetus has implanted itself here, or in the implantation process, what it does, it sends out finger-like protrusions which grows right through the decidua, and eventually in here you can see this bluish part is the muscle part of the uterus, the myometrium of the uterus. So these finger-like protrusions grow right through the decidua and the muscle layer of the uterus. And eventually this will become then the villi that is being filled with the branches of fetal arteries and fetal veins, which brings blood to the placenta and takes blood away from the placenta with the umbilical cord. Here you can see the umbilical cord, so the fetus, this is the uterus, and the fetus will be somewhere here in the uterus. So now what happens, before I say what happens, what's very important here is that when these finger-like protrusions grow through the decidua and the myometrium, it grows literally through maternal arteries and veins as well, so that these arteries and veins are literally opening here in the what we call maternal fetal blood circulation, and makes that these villi is being absolutely surrounded by maternal and fetal blood. Now what happens during preeclampsia is that something goes wrong in this development here, and specifically the growth through these arteries and veins. Now, I've said on the previous slide that something goes wrong when these finger-like protrusions grow through the decidua and the myometrium, and we have said that it grows right through the maternal arteries, and here you can see it. And what happens then is that this part that has grown into the maternal artery is being widened, and that makes that lots of blood can come in here. The villi that you've seen on the previous slide will be here somewhere, so that the maternal blood is literally all around these villi and can cause and can give oxygen off to the fetal blood. So we see here that the trophoblasts, that's the part of those finger-like intrusions, invade the decidua, and it extends into the walls of the spiral arterioles. These are the maternal arteries that comes into the uterus, into the endothelial and the muscular wall, and it creates a low resistance vessel that can go now here to surround the villi. Now, in this part of the photo or diagram that you see here, is what happens here is now, for some reason, and we will come to the some reason now, which might be genetical or immunological factors might play a role as well. For some or other reason, there's a defective implantation. This growth of the trophoblasts is not as actively as in this case, and this makes that there's not as low resistance vessel that's been forming as here, and we have a very much smaller area of here, and there's much less blood going to the villi, and that causes hypoxia, and this hypoxia here is what's causing all the problems around preeclampsia. So in a nutshell, what I've said just now is in preeclampsia we get the invasion of the myometrium and spiral arteries by the placenta trophoblast, that's those finger-like protrusions from the fetus, and it's inhibited. This growth of the placental trophoblast is for some other reason inhibited, and that makes decreased placental perfusion, because those I almost wanted to say those funnel-like growths is now too small, and it causes hypoxia in the placenta. And this hypoxia in the placenta is a big problem, because it triggers the release of factors that cause damage to the endothelial cells in the maternal circulation. And this sentence is basically the most important sentence of preeclampsia that you will hear quite a few times now. This hypoxia in the placenta triggers the release of factors that cause damage to the endothelial cells in the maternal circulation. Now, what is very important is that there's endothelial tissue in every single organ in our bodies and in the blood vessels. So these factors that's now been formed because of hypoxia causes damage to all endothelial tissues, specifically the blood vessels, but also to other organs, and we will come to that just now. Now, I've said previously that it's not known what causes this problem, this fault almost in the growth of the or the protrusion of the placental trophoblast that causes this hypoxia. And this is also where there are many theories. Immunological factors might play a role, or genetic factors might play a role, and that's might be why some women get it and why some other women don't. Now, we've said on the previous slide that the endothelial tissue in all the blood vessels and the organs are being affected. And this causes vasospasm, and vasospasm means all blood vessels are in a spasm, and that obviously will increase blood pressure, and that's where the hypertension is coming from. So that's our first main effect of this pathophysiology, the things that are going wrong in the placenta. Then secondly, because of also the endothelial tissue of the blood vessels that's been affected, we get increased permeability of these endothelial tissues of the blood vessels. And that makes that more fluid is going from the blood vessel into the tissues. And that causes increased edema. That makes also that protein leaks out, specifically in the urine. We will come to that just now. And because of this leakage, because of the fluid leaking out of the blood vessels and going into the intracellular space, as I've said, we get increased edema, but we also get hypovolemia in the blood because of the fluid part of the blood that's leaking out. But this doesn't cause the fact that we have hypovolemia, doesn't make the blood pressure to go lower because we still have vasospasms. And then later we also get a problem with the leakage of some platelets and fibrinogen, and eventually because of this endothelial tissues that's been affected, and we get abnormal coagulation, and abnormal coagulation is a very important part of preeclampsia. So to just summarize what we have said now in the previous slides, we get vasospasm because of the endothelial tissue that's been affected, and we get more interstitial leakage. In other words, the fluid part of the blood leaks out into the cellular space. Now, because of this vasospasm, we get that there's ischemia in the surrounding tissue, because obviously in vasospasm the blood flow is being decreased because all the blood vessels are in a spasm. So we get ischemia, and you will see again and again when we go to the different organs now, that is one of the big problems that causes organ damage, and that causes, as I'm saying, necrosis, hemorrhages, edema, and other organ disturbances. So because of this vasospasm and the effect, ischemia, which is the effect of this vasospasm, we get necrosis because there's not enough blood flow to the different organs. And that also, the necrosis causes that blood vessels are being damaged, and that causes hemorrhages. We have edema because of this leakage, and that causes all the problems in the organs. Now, if we look at each organ all by itself, let's call blood the organ, the effect of the pathophysiological changes, or the pathological effect, I can almost say, because of all this effects that I've discussed in the previous slide. Now, what happens in the blood? First of all, we have said that we get hypertension, and because of that, because of the vasospasm, and we get the increased permeability. And we have said that we get increased edema in the intracellular space and hypovolemia intravascular. So there's more fluid in the cells and less fluid in the blood, in the circulation. And that causes hemoconcentration. That means that there's more fluid going out of the blood, and that makes that because of and the relationship between the cells, the red blood cells and the white blood cells, etc., and the plasma is getting smaller intravascular, and that causes the hemoconcentration. Now, what is very important also is because of this increased permeability, we also obviously get increased permeability and edema in the lungs. And this is one of the main causes of maternal mortality during preeclampsia, serious preeclampsia and eclampsia, is as the fluid is seeping out in the rest of the body, it also does in the lungs, causing lung edema and causing eventually the death of the patient. And we will come to lung edema back again and again because this is very important. And then the other very important thing that happens in the blood is that the coagulation cascades being activated. We get a lot of changes in the whole coagulation system in the blood, if I can call it like that. We get fibrin clots that forms, we get increased platelet consumption because of that, and eventually we get DIC with low platelets, prolonged prothrombin time, and low fibrinogen levels, which cause a big coagulation problem for us when the condition gets really serious. Now, if we look still at the blood, there are very important aspects here also to take into consideration. I've said that the hemoconcentration gets more because the fluid leaks out. We also get hypovolemia during with preeclampsia, and this is very important for us when there's blood loss. The patients, because of this hemoconcentration and hypovolemia, the woman can't really cope with blood loss if she has serious preeclampsia, and that's something very important to take into consideration. Now, this vasospasm and interstitial leakage, which is basically the prime pathology of preeclampsia, unfortunately persists for quite a time after the delivery of the placenta, because the only way in which this condition can be cured is to deliver the placenta, because all this is going wrong in the placenta, and as long as the placenta is there, it's going wrong. So this vasospasm and interstitial leakage will be there as long as the placenta is there, but also then for a while after the placenta is gone. And that is why I keep on saying it is so important to really assess these patients very well in the postpartum period, that we don't think, oh, the problem is now solved, we don't have a problem anymore. We still do. And then, very important, the lower platelet count is also very important in the maternal and fetal morbidity and mortality. So the coagulation problem in preeclampsia is a very important problem. Now, when we look at the kidneys, in the kidneys we still have vasospasm like in all the organs, and this causes a decreased renal blood flow to the glomerulus. And we know that in the kidneys we have the glomerulus where all the filtration happens. So this vasospasm leads to a decrease in the glomerular filtration rate, the blood that filtrates through the glomerulus where all the filtration actually takes place. And this makes as a big effect on what is being filtrated out of the kidney. Here we can see that this, because in this glomerulus is also a lot of endothelial tissue that also has been changed a lot and is becoming more permeable. But the changes now makes that filtration is being blocked. So this glomerulus can't do its proper function as it normally does. That makes that creatinine can't be filtrated out of the urine. So we get that creatinine heaps up in the urine, in the blood. It's less in the urine and more in the blood, where it's supposed to be filtrated out of the blood into the urine. So when we test the urine, we get reduced creatinine clearance, and if we test the blood, we get the increased serum creatinine and uric acid, because the filtration is being now changed and effective in this glomerulus. And then also because of hypoxia and edema of this glomerular capillaries, we get damage, because wherever there's hypoxia, we get necrosis and damage, and that causes that more protein is leaking out. And that is where the proteinuria is coming from. And then eventually a late sign of preeclampsia, because of all these changes in the kidney, is that we eventually also get oliguria, that the total excretion of urine is becoming less and less. Then when we look at the liver, it's very similar. We again get vasospasms and interstitial leakage, and this again leads to hypoxia and edema in the liver, and this leads to tissue infarction. So parts of the liver will also be affected and damaged. Now this edema, together with some bleeding as well, causes swelling of the liver. And the liver is being surrounded by a capsule, as you know, and this swelling of the liver within this capsule causes epigastric pain. So the patient might complain of an epigastric pain on the right side, and this is one of our late signs, or a very important sign of preeclampsia that's getting worse. Now, all these hemorrhages, little hemorrhages and infarction because of this hypoxia and tissue infarction is causing that the liver also can't do its function properly. And we get altered liver function. So if we do liver function tests, we will find that the liver function tests are being changed. And because of that, we get a rise in liver enzymes. Because of all these damages, we get a rise in liver enzymes. So these two values are also an indication for us of how serious the condition is. Then if we look at the effect of the preeclampsia on the brain, again, we get vasospasm and interstitial leakage. And again, because of this vasospasm, we get, and the leakage, we get edema, cerebral edema, and microbleedings because of the small infarctions. And this can be small and can stay small bleedings, or it can become bigger and make small or bigger hematomas. And this edema, together with the bleeding, cause the visual disturbances and the headaches and the convulsions eventually. So visual disturbances, flickers before the eyes, and headaches are also two of our very important signs of imminent eclampsia. It's a late sign, and convulsions obviously a very late sign, and the patient is already developing convulsions and eclampsia now. These bleedings and hematomas might become bigger, and that eventually cause big cerebral hemorrhages and death, and that's one of the other reasons why patients die of preeclampsia. We've said pulmonary edema is one of the big causes, and cerebral hemorrhage is one of the other big causes. Now, we've said that usually together with the vasospasms, we get ischemia, and then eventually also small infarctions in the brain, and that also causes many of the brain signs and symptoms, the visual disturbances, and as well as the headaches. Now, convulsions eventually is being caused by this, together of excessive release of excitatory neurotransmitters. In other words, it causes things to make, I almost want to say, to make the nervous transmission, the transmission of nerves very excited, and that eventually causes the convulsions. Now, if we look at the fetoplacental unit, what happens in the placenta? Exactly the same. We get vasospasm and we get interstitial leakage. But specifically in the placenta, the vasospasm plays a very big role because it causes a reduction in the uterine blood flow because the blood pressure is now so high in the placenta, there's less blood going. And remember, we've already said that there is hypoxia in the placenta because of the formation of the placenta. So this all causes the problems in the placenta. The reduction in the uterine blood flow can result in placenta abruptio. It can make, because there's less blood flow to the placenta now, that some parts of the placenta go loose. And that causes placenta abruptio. And that's very important. We will talk about placenta abruptio more in our further lessons, and definitely in our next course where we talk about obstetric hemorrhages. Then the other very important thing is, as we've said, there's hypoxia in the placenta, and that causes reduced oxygen to the fetus. And that eventually causes intrauterine growth retardation and a compromised fetus. Now, all these factors, all these effects on the different organs obviously depends on how serious the condition is and how well controlled or uncontrolled the condition is. The better controlled the condition and the less the vasospasm, obviously the effect will be less on all these organs. Now, also, one of the big functions of the placenta is to produce hormones. If the placenta can't function properly, obviously the hormonal function will also be affected. So the hormonal output is eventually impaired. Now, who are at risk for the development of preeclampsia? All women are at risk for the development of preeclampsia. As we're saying here, all pregnant women, any pregnant woman can develop preeclampsia. We have some high-risk factors. Some women are just more susceptible to developing preeclampsia, and you can see them all here. Primigravida, teenagers, and elder primigravida, so the youngest and the oldest. People above 35 years. I think in general, women over 35 years gradually do develop some circulation problems, and that might contribute to this system. Previous preeclampsia always tends to repeat. Chronic hypertension. Previous abruptio placenta might have been associated with previous preeclampsia. Multiple pregnancies, medical complications such as chronic hypertension, renal disorders, even diabetes. Women who develop severe edema in the mid-trimester is usually a sign or a possible sign of preeclampsia. And then obese patients, patients with a BMI of over 30. And that brings us to the end of lesson 2. What is so important to me, and we will come back to that in the next lesson where we come to the management of an assessment of patients with preeclampsia. Every single thing that I've taught you in this pathophysiology and physiology is so important when we do the assessments of the patient and when we start treating the patient. So that is why it's so important to understand it and to be able to apply it. So I really hope that you've gained some knowledge in this.